lymph nodes, the inferior vesical lymph node. Now, clearing these group of lymph nodes surgically often places the vasculature there at risk. When you are doing a total cystectomy and removing out the bladder, it does not matter to take out all those vessels. But when you are keeping the bladder in situ and maintaining those vessels and vascularity is very imperative. So I know with a good technical skill set, obviously you will be able to save it. But that is done, but like even in joint node dissection of the pelvic node part, so that is the same technique only. Preserve the bladder and spray this. It's not sadly taken care. Comment on that. Yeah, we do see more of pelvic nodal recurrences because one reason is because the patients who are ideal for bladder preservation strategy would have already undergone a maximum TURBG. So you don't really have a gross disease in the bladder when you're giving radiation or chemoradiation to that. So we do see more recurrences in the pelvis. So the radiation guidelines don't say really to do that. But of late, we have been starting because the patient numbers are small to give a categorical thing. We don't have any RCTs for that. I completely agree with this comment that RCTs are lacking, and hopefully more and more prospective data will come because most of data is retrospective. So that's a big limitation. In fact, multiple RCTs were started there to withhold due to less recruitment of the patients. That is why these trials were never completed. So we don't have any category. Thank you. Thank you for the comments. Thank you. Now we move on to our next session. It's a panel discussion. I would like to Dr. Akhil Kapoor, consultant in OIC Medical Oncology Department at UMC Varanasi. Selecting the therapies in advanced urothelial cancer, the panelists will be Dr. Ankit Joshi, Dr. Shashank Seni, Dr. Satyanarayan, Dr. Somnath Dey, Dr. Anil Gupta, Dr. Ankita Kapoor, Dr. Nagendra Sharma, Dr. Atul, Dr. Praveen, and Dr. Loken.
So this will be a very informal discussion because we have discussed so many guidelines in last 2 days from yesterday only. But the main focus will be on the practical aspects which we face problems. So the focus will be on that. And I will also request Shrita ma'am to give comments from the pathological perspective. So these, when we see the treatment options, we have a lot of options now, and it becomes difficult to select the treatment sometimes. Let's before going to the metastatic setting, I would start with another gray area in uro-oncology, that is patients where the patients are not fit for cisplatin in the neoadjuvant setting. The guidelines suggest to go ahead with directly surgery. I will request comment from Dr. Shashank first. What are the expected outcomes in the patients who are not fit for cisplatin if we go ahead with neoadjuvant chemotherapy, and especially for patients who are node positive? We were discussing node positive just before. I request his comments. Expected outcomes in such patients.
For the patients who are planned for this neoadjuvant chemotherapy, actually we are seeing T2 and T3, we are discussing T2 and T3, especially node positive disease. It is always good the patient gets, but in our clinic practice, as you said, there are numerous occasions where we see patients are ineligible for this, maybe due to the basic biology, involvement of the VUJ leading to hydronephrosis,
These, I think, are some of the reversible causes which we can correct. And if we correct, as per the literature, we see giving GEMS has been discussed in the last 1.5 day. GEMS is definitely superior. And giving, if we are going for GEM carbo, then the outcomes are not that good. Even it actually delays the definitive surgery sometimes. We are not getting a complete response. One more thing you have not included, sir, in this is DDMVAC, which I think very few patients have received in the last 2 years. But those who have received have like excellent response. Some of the patients, when we have done radical cystectomy, they're actually there is no disease in the spine specific. Yeah. So, for my take on this will be
So fit patients should receive TT.
yes. Some discrepancy and then go for a radical cystectomy.
Okay. So now we have got a comment on DDMVAC, requesting comments from Dr. Nagender. So what is uptake on DDMVAC in the routine practice? How many patients are able to get it, and how do you select those patients?
So we all know that so the training days also the DDMVAC is considered to be one of the toxic regimen. Only point here is only those patients who are young or fit or good organ system reserve, those patients only you could challenge. So in clinical practice, majority times, as I in my presentation also I told that majority patients are getting diagnosed in advanced stages. They are having the low performance status. These are not the correct candidates for DDMVAC because we don't want to burn our hands because we are doing for 30 patient lines of the ICU. All of the other people are also
Compromised.
only in the right fit with these patient who are young, fit, good organ system reserve. These are the candidates for
DDMVAC.
DDMVAC.
In the routine practice, how many patients will you able to get it? A rough percentage?
So 1 out of 10, I will put it.
1 out of 10%. 10%. So also we agree that in our practice also the situation is similar. Around 10% will be only fit for. In fact, giving GEMSIS full dose becomes sometimes difficult in such patients, and most of the time we divide cisplatin. Though the standard recommendation is to go cisplatin on day 1 fully, but we divide it in day 1 and day 8 so that the patient can tolerate the cisplatin. Now, coming to the another problem, requesting comment from Dr. Ankit, that when the patient is N2 disease, patient is not fit for cisplatin. Upfront radical surgery. What do you think? What is the expected outcome in such patient N2 disease on the radiology? Yeah.
If the patient is cisplatin ineligible, so the other therapies might not give that much result. So better to go with early surgery, but the prognosis will not be comparable with some N0 disease.
Yeah. Okay. So the main problem with N2 disease, actually, it is basically called as N2, but it's basically already a systemic disease. That is the problem. Yeah. So there are already micromets. So in fact, we are not able to give GEMSIS like treatment in these patients. But now I think off-label we have started to use immunotherapy in these patients. There are already some data from phase 2 trials. There are data from the PERSEC study. There is data from another trial for both pembrolizumab and nivolumab. So these phase 2 data extended follow-up has been presented this year's ESMO. So this data is now available that we can consider immunotherapy. And also now the data for chemotherapy in combination with nivolumab has already presented for advanced metastatic patients. So we know that the combination is at least safe. So on the base that premise, we have started 1 or 2 selected patients now on gem carbo plus immunotherapy, because we know that gem carbo alone might not be the best neoadjuvant treatment. So if we can add something that might give, but we don't have level 3 evidence, level 1 evidence, that is completely off level. Like, I completely agree with that. Any comment, Dr. Anuj, on this point?
Definitely, we need to improve our response rate in the study, and in adding immunotherapy in metastatic setting. We have seen that these immunotherapies have improved the response rate and survival. So maybe with time we will get the role of immunotherapies in neoadjuvant setting as well. So as of now, off-label indication in a fit patient, we can add it, not.
Also, the data for enfortumab is very encouraging. It will, the trials in the neoadjuvant settings are ongoing, especially who the patients are cisplatin ineligible. In metastatic setting, the first line, irrespective of cisplatin eligibility, the data for enfortumab has already come. But now in the neoadjuvant setting, for patients who are cisplatin ineligible, enfortumab plus pembrolizumab might be a very good option. That seems, again, this is a gray area in uro-oncology. Again, I wanted to highlight, we are discussing today gray areas only. other areas we have discussed our previous conferences as well. So concentrating on that gray area. Now, coming to some of the comorbidities, I will take comment help of our dear colleague, Dr. Praveen, who has helped us in our geriatric clinic a lot. We have developed a vaccination schedule for these patients as well. We know that these patients are most of the time older, more than 60 years in our settings, most of the time. So, Dr. Praveen, first your comment on the vaccination, then how best we should able to optimize the comorbidities of such patients. What should we take care as a clinician? Comments from both surgeons, medical oncologist, and radiation oncologist.
So regarding the vaccination, first question. So ideally, all the inactive vaccine is recommended for the patients who are going on chemotherapy, and the ideal schedule should be more than 2 months from the starting of chemotherapy. So within 2 months, it is risky because the inactive vaccine will not be efficient in producing the antibody response. So the ideal timing is within 2 months from the after 2 months.
2 months of starting vaccine.
Yeah,
Yes.
after
But
chemotherapy.
another point here, just now I would like to highlight regarding the COVID vaccine. The COVID vaccine, when it was started to be utilized, there was a concern that combining with chemotherapy might be difficult and COVID vaccine will not produce the results. But later data came with COVID vaccine can be given simultaneously with chemotherapy and there's no harmful effect. Yes, if it is very immunosuppressive, the generation of antibody will be lowered. But that is we understand.
So there are two vaccines which can be given during the chemotherapy. Also, one is influenza vaccine, and the other is COVID vaccine, as you said, because something is better than nothing. So small amount of antibodies do provide immunity. So
Yes.
that is the point.
Okay. Now, a message to all the team, your oncology team, medical surgical radiation about the management of comorbidities. So sometimes these patients have significant amount of comorbidities, including cardiac comorbidities, diabetes. So any specific message, how should we best tackle and should these patients, what basic workup must be included on the day one itself so that these patients are not delayed for the treatment?
Definitely with the cisplatin-based or adriamycin-based therapies, the cardiac comorbidities is more common. And here it's the asymptomatic cardiac comorbidities we are seeing in the recent practice are more common. So we need to screen them with the screening echo and GLS scoring. So that we can detect the cardiac comorbidities earlier and then can institute the treatment to improve the quality of life. And also with the ADT-based therapy, of late we have seen a lot of derangement in the lipid profiles. So we have instituted the lipid profile in our protocol also in our geriatric clinic. So to screen for the lipid abnormalities. So these things has to be taken care.
So I think the baseline workup itself, we should send these investigations so that it is not delayed from when the patient is sent for any further treatment or new adjuvant treatment. So these investigations should be covered at the baseline. So that's another request for the entire surgical radiation and also medical oncology team that include at least lipid profile, HbA1c, because these patients are mostly older patients above 40 years of age at least. So I think we can include that. And now, as Dr. Praveen also highlighted about the importance of GLS score. So I would like you to highlight again what is GLS because some might not be aware of the GLS.
GLS scoring is global longitudinal strain scoring, which will suggest the length of the myocardium and the stress which has been put on the myocardium because of the various chemotherapeutic agents. So this with this we can early predict the chances of going into the heart failure. So we can prevent heart failure. The GLS score is picked up early and which can be treated early.
Yeah, so it will help in preventing symptomatic cardiac failure, which might completely denies the entire treatment of the patient, which we have seen. Now, coming to the symptomatology of the patients, these patients have at least significant symptoms of LUTS at the baseline, and sometimes becomes very challenging how to manage the symptoms, especially in advanced cases. I would like to take comments from Dr. Somnath, who is our palliative care expert, to give comments. What symptoms we should take care, what are the available medications, and how to deal with them.
The important symptom is that
irrespective of the stage and irrespective of the stage of the disease. So we often encounter the pain and even the hematuria because most of the time we saw the patients coming with hematuria. And that is also a very challenging situation, especially with advanced cancer. And obviously metastatic symptoms like even urinary retentions, urgencies, frequencies, overactive bladders. So these are the very common symptoms. And sometimes you often miss to treat the UTI because underlying UTI also uh, presents and silently. So we should often check the at least urine microscopy for routinely for any kind of bladder malignancy patients because that will give a lot of hints. And even sometimes patient has also the little bit of renal damage associated with that. Sometimes you see that patient is having RBCs and WBCs and is coming in. It's simply micro. So that you often miss. So my idea is that if any patient comes to us that we, along with that, all these cardiac profiles, lipid profiles and all that, so urine routine should be included for any urological malignancies to see that baseline whether anything is going on to the kidneys or not. Just if something we see any abnormality, just to rule out the UTI and other symptom based on that overactive bladders. This is very common. So we have to treat that. And pain, as I said, and other symptoms. And even sometimes patients come with fatigues and breathlessness. So that is also that even the disease metastasis to the lungs and other things. So fatigue and breathlessness is also the problem.
So these are very important points, but in the busy clinics, these are mostly overlooked. So the patient is having so much symptoms, but patient is sometimes not able to give clear history also, because it's very difficult for the patient to explain what is actually happening. Shashank, I would like to request your comments because these symptoms are very distressing for the patients. We classify as broadly as LUTs, but there are so many different aspects to it. How should we bring out the history and what different medications are available for different symptoms?
The slide is on metastatic urinary carcinoma, and Somnath sir rightly mentioned about almost all the symptoms are covered. But what I think the management as a clinician, we should first think about the gentry of patients which we are treating. It's not about the socioeconomic status. It's about the baseline patients we are treating. Dr. Nagendra will be treating some gentry different in next Saket that what we are treating in Banaras. So that should always be kept in mind how our patient is managing to come to our hospital for a treatment. That should always be kept in mind. And I think, sir, you will agree. I have sent a lot of patients to you, and you have been like, on day one, we are able to start chemotherapy, especially CATST and all these patients. So we have to have some empathy with the patient, how they are coming to the hospital and the symptoms, and our counseling should be based on that. Like sir said, urine microscopy should be done. I have a small modification in that, especially in metastatic settings, when these patients, all of us will be agree that these patients will be on chronic indwelling catheters. And our counseling helps a lot. If we can simply teach them to keep local hygiene, then probably there is no need of doing routine microscopy in every case. And a lot of antibiotics are given simply for asymptomatic bacteria. If we do urine RMs in this patient routinely, they inevitably drug MDR positive, even NDR positive. And if we look at clinical, patient will be asymptomatic. They will be count will be normal. They will no fever. So that we have to see. Our time spent with the patient in counseling is more important. And I think symptoms in this patient will be there. We have to accept that. But we have to keep our drug doses instead. It should not be. We have a long list of 20 medications for the patient, and the compliance is almost 10%. He's not taking, I think, 5 drugs of that. I think talking to the patient is important. And regarding the symptoms, as soon as possible, if you think as a surgeon, what I can say, symptoms we can intervene, we try to intervene. Like which areas are mentioned. If the patient is fit, is ready to go on table, we routinely take this patient for participation, even under local anesthesia, since we have constraints. So Ankit is like most active in that. Even 5 o'clock, 6 o'clock, we are taking up these patients for clot evacuation, and that leaves the symptom. We have to understand the patient is going remaining with the clot for 20 days, getting it done, even if it is odd hours for us, we do it. So I think empathy, understanding the patient, and giving time and understanding the gentry of the patient is important. My message.
I would like to add one thing that even the hematuria thing that we often see that people are many residents. I'm not talking about consultants. Is prone to give kind of tranexamic acid and all that. So it further complicates the situations because of the clouds and so we go on. So early identifications of microscopic hematuria and treat accordingly, whether it is embolization is required or any palliative radiotherapy is required or anything with bladder elevation is required. So that should be done very early.
Yeah, so that's an important point. Two main important points have been highlighted. One is about the use of tranexamic acid, which is not recommended in urothelial cancers to stop the bleeding because it will further lead to clot formation, and that is most of the time overused and not recommended. Another is the utilization of antibiotics for asymptomatic bacteria, which is very, very common in these patients. This will be present in 50 to 60% of the patient when you are testing for the same. So it becomes very important not to treat, even the cultures will show MDR. So that is it is not an indication to start nitrofurantoin or such treatments.
They get sensitized that okay, this catheter is bad, I have to get it changed. The cycle starts outside this hospital. They will start getting the catheter change outside at some shady places, and around 50% of them will get their urethra damage. So now we have no way to put a SPC. This key for now we are putting a SPC. So the way that has to be taken care of.
And even transactional anti-Trenexa can be given with irrigation.
With irrigation.
Yes.
So
The
that
other thing is, for all these patients, we should check the patient is able to empty the bladder completely. That will be the main reason for UTI. And if there is some mark that maximal TURBT should be done at time appropriate before he starts to develop his mind.
So that's another important point. So the post-void residual volume checking is important in such patients.
Overactive bladder is another area that most of the patients often comes to our OPDs and other things. So that usually recently we treat with anti kind of interferonetic drugs like beta-2 agonist like mirabegron, davidgrons, so that is also we would like to have.
Yeah. Now, another important symptom, which not only urothelial, but a lot of our breast cancer patients face, colon cancer patients face. We have surgeons from both the DMGs also available. So I would like to get a comment from first Dr. Anuj, then from Dr. Atul regarding the neuropathy. It is a very, very common problem in our scenario, what I think. Let's get comment from Dr. Anuj.
So, neuropathy is very common, as you told. And the worst part is that in our VCOPD, we are not able to take a proper history most of the times. And the patient also ignores in the beginning because they think it may be something due to chemotherapy. They don't
Understand.
understand the importance that that may progress and that can be permanent. So it is our clinicians' job to ask repeatedly in each visit whether they are having the neuropathy, and we have to explain in all the possible terms, not just we have to ask the kuch in the local language, but we may have to ask about the pain, about the tingling, about the burning. We have to give all the options to them so that they can understand that it is important. And we have to explain them that become very important because if we are in diagnosing it early and starting treatment or withholding the treatment when required, changing them, that is very important. And before starting treatment, again, the comorbidities which lead to neuropathy, like diabetes, which is very common. Uncontrolled diabetes is very common in our setting, and patients tend to forget diabetes medicine when they develop cancer or they are on many chemo medicine, support medicine, that they tend to ignore or and when we are giving Dexa and other steroids, then it becomes uncontrolled. So that becomes very important. So initial workup, initial counseling, and then repeated monitoring of peripheral neuropathy and a timely intervention in terms of dose modification or changing chemotherapy is very important for such.
So now, Dr. Nagendra, do you think we have any sufficient good drugs for peripheral neuropathy management? What is your experience and what are the armamentarium you have?
I think I can answer better, but only this, there are agents which we are using. First of all, we have to grade the neuropathy. Many times we are not grading them, right? So if it is a grade 1 or grade 2, there are drugs which can be done, like all of us are using brigatinib, gabapentin. All these drugs are there which can be used in the lower doses, and we can escalate depending on the response. And we make sure that the comorbidity, like that the patient has diabetes, make sure that diabetes adequately is solved. So we have to get personalization from endocrinology, from the neurology, but all regard. We can do NCD studies, love condition velocity, which can be done. And then we have to take our action judiciously, and we have to make sure that this therapy can sometimes be devastating for the patient because they cannot enjoy the quality of life, right? So that's why we have to make sure that we take the
So, Dr. Atul, you have given us a very enlightening talk today regarding the utilization of some newer formulations which are coming up. So I will take your comment, then Dr. Somnath's comment.
So what is I don't know, I'm just talking about like a scientific view that neuropathy comes from like either like chemotherapy induced neuropathy is come from like from peripheral areas. It should not go to the like central areas not majorly damaged. So what we are misunderstood, I think there is that every time we use neuropathy, these are the central acting drugs, but what are the major damage has come to the localized area. So you see the thing like
Yeah. So it's a glove and stalking pattern, which we commonly see.
and most of them like lidocaine and all. I think it has itself has their own side effect. Like lidocaine includes headache, something about shortening of breath. So there is like the other, as I mentioned, that pain, without chemically, urban sulfate. So we have like the formulation for this. Like this is already marketed as a Milo. And in our area, most of the medical colleges are using for the uh, indication of the neuropathy. We have a very good result from that.
Yeah.
But
So we are also planning a randomized
yeah,
trial for the
right,
same
like
recently. It is.
I think that would be really a blockbuster for this neuropathy.
Yeah, actually, it's an unmet need. I completely agree. Dr. Somnath, we utilize pregabalin, duloxetine. The problems that these are highly sometimes cause significant amount of sedation, significant amount of dizziness. So your comments on?
Yeah, first of all, as we need to know that the grading, when we are dealing with the neuropathy, peripheral neuropathy particularly. So first is grading is important, then etiology is important, and the cofactor is important. So first is if we know the patient is already has a diabetes, should treat the diabetes. Patient is already having combinations of chemotherapy, which is more prone to develop the neuropathy, so need to reduction of the dose or the changing of the chemotherapy that sometimes is treat the reversible causes. And obviously the medication. Medications we have to think about that based on the grading. So there is a grade 1, grade 2, and grade 3. First is when it is grade 1, there is a neuropathic peripheral neuropathy. As far as the guideline, WHO guideline, we have to start with a single drugs. It's not the two drugs. Single drugs is either pregabalin or the gabapentin. When it is not working, then we have to move to the step 2. Step 2 is combination of pregaba, pregaba or gaba or amitriptyline, any of these. Then step 3 is combination of the step 1 and step 2. Then step 4 is add the tramadol. So then step 5 comes other things like local things that he mentions about the lignocams and all that. And here different multiple combination is available. Like that's the inocetrols and all that's different combination, and methyl cobalamin is always help. So that is the reason. But when we give the combinations, we have to be careful about the side effects. So side effects means obviously pregabalin cause the more dizziness than the duloxetine. So as much dose you are using, and you have to always titrate. And neuropathy that we have seen in our clinical setting that when we combine with 2, 3 drugs, so many of the patients develop the good symptomatic improvement within a 1 to 2 months. And yes, obviously they have to take the medications for a long time, within the 6 months to 1 year. And sometimes I have seen that many patients, when even some paclitaxel, induced neuropathy, taxane-induced neuropathy.
Yeah, it's very common.
So it's
Vaccine
very
induced
common.
neuropathy is very
And even the patient with having this kind of gloves and stock neuropathy is unable to tie up the button, even and is all these things. So these patients, I have seen that is improved completely, not to say completely,
but it's
after,
significant.
significantly
Yeah.
after 6 months of treatment.
So, so the benefit with paclitaxel that neuropathy settles down with time, but oxaloplatin neuropathy is very different. It's very difficult, and it keeps on increasing also because it gets accumulated in dorsal root ganglion and keeps secreting. That is why oxaloplatin neuropathy is more difficult in the real practice.
So that time that I tell that you have to send back the patients to the medical oncologist to reconsider the dose and changing the chemotherapy when we are seeing that neuropathy is getting worse. So
Yes.
Very common. Because our patients are malnourished, to make sure that multivitamin should be there as a part of treatment, because vitamin B12, vitamin folate deficiency, and then we check the level comes to know. So make sure that multivitamin also is a part of the treatment protocol, and that will help in taking care of the deficiency, which causes neuropathy.
Completely. Now, coming to another part of important palliation is regarding the radiation treatment for the patients with advanced disease. So these patients have a lot of bony symptoms. Bony mets is an important part. Requesting comment from Dr. Ankita, how do we screen the patients whether the patient will get benefit from palliative radiotherapy or not? What is done in the OPD?
Severe pain not controlled with any oral drugs, or secondly, it could be impending cord compression, or third, it could be unstable spine. All these three will require palliative therapy, and preferably within 24 hours if we want the power to be improved in cases of impending cord compression. And also in severe pain, we need to give it as soon as possible. Single large dose of palliative therapy is enough. But if there is a soft tissue mass which is causing the compression or the pain, so we can give fractionated arteries up to 5% fraction. Another indication for palliative artery could be hematuria, which we were talking now. So for that, we have to give within like as soon as possible palliative artery, a single large dose up to 6 to 10 gray of per fraction. But that takes around 24 to 48 hours to act. So that we have to keep in mind, and for that 24 to 48 hours, we might require other therapies like bladder irrigation, maybe we can continue. So we need time for RT to act to stop the injury.
Yeah, so it will take some time. Yes. Another thing is that when we are instituting radiation, at the same time, we try to start the patient on some bone modifying agents. So that should not be missed. Most of the time, if it is missed by the residents, we try to keep that in track that apart from radiation, at the same time, institute the bisphosphonates or denosumab, whatever is feasible also. Now, again, comes the role of here, our dental team, that what precautions should be taken before instituting or zoledronate or denosumab in the practice.
Thank you. First of all, the topic is gray areas in urothelial cancers. So for me, it's gray square. Because if it is gray for medical oncology, radiation oncology, and surgical oncology, definitely for me, it is square. So coming to the bisphosphonate and denosumab and other therapy on modifying agents. Generally, that side effects comes in the jaw most mainly because of the high turnover rate. So generally, we advise that if any plan is given for denosumab or any kind of bisphosphonate or anti-angiogenic therapy or any kind of chemotherapy, we are conducting one prevalence study also with Dr. Anuj, how that chemotherapy giving side toxic effects. So our recommendation is the patient's oral health has to be evaluated before starting
The bisphosphonates or
bisphosphonate or any therapy. So we are checking if other chemotherapies also affecting the jaw bones. So, but bisphosphonate is definitely it's a known fact. And another thing is we generally correlate with the half-life. So suppose if any chemotherapy is given, and if half-life is how much is the half-life, and then if suppose patient is already on chemotherapy and developing any oral symptoms, then based on that half-life, we calculate that at what time we can proceed for dental treatment, because that has to be, that jawbone should not be affected, but it is not true in bisphosphonate. The half-life is less, but the accumulation of bisphosphonate in the jawbones is for longer duration. So giving a drug holiday of 2 months, I don't know, it's a debatable topic. Giving the drug holiday for 2 months will, give relief or not, but definitely we try to intend that the symptoms will be reduced. So the take-home message is to that oral health should be taken care before starting a chemotherapy.
So that's an important part which is sometimes overlooked, and that is why I thought of discussing this point and taking it for our residents and consultants, that this is very important to be included for them. And also another point is, when we are giving large fraction of radiation, at the same time, most of the time we require to give steroids as well. And Dr. Ankita, what is the importance of instituting steroids when we are giving large fraction radiation to these patients?
Cases of bone mets and impending cord compression, we have to give steroids. And in cases of sometimes hematuria, like pelvic RT, when we are giving large doses, like up to 10 gray also, we can give. So we might think of starting low dose steroids for tapering for around 7-8 days. Tapering dose is enough to control the.
So now again, here comes the role of our medicine team. So these patients are requiring steroids. What is your suggestion? Instituting insulin at the correct time, what if it morning dose or evening dose? What is important? Because some of these patients are already diabetic, and we tend to miss instituting the insulin or everything which is required, because even Dexa 4 milligram BD, if instituted, can cause significant hyperglycemia and will completely derange the entire treatment.
Definitely a very good point to be discussed over here. So regarding the steroids, it all depends on the duration of action and the peak of action of the steroids. So whenever we are giving the short acting like prednisolone and all, so the peak action will coincide with the mixed insulin, that is NPH insulin. So whenever we give a prednisolone based treatment, so it is ideal to start NPH along with the prednisolone.
Okay.
When it comes to the longer acting steroid like dexamethasone, here comes the basal insulins. So basal insulins are more useful in the longer acting steroids. So what we do is we divide the dose of the basal insulin and give 50% in the morning and 50% in the evening.
Yes. So that is very, very important. Steroids are very, very commonly used in the clinical practice in advanced patients. It is important to utilize long-acting insulin as well in the morning and evening divided doses. That is the present recommended schedule. And basal bolus regimen can be utilized if required. If the sugars are still not controlled, add bolus insulin, the aspartame
insulin.
Yes. Aspartame can be easily utilized in the routine practice. And this part I'm discussing because these are commonly missed in the routine practice. Other things we have more or less discussed, but these things are very, very important, but missed in the practice and leading to completely different outcomes. Uncontrolled hyperglycemia, again, the patient will develop UTI, will be started on multiple antibiotics, will be requiring prolonged hospitalization. So this is very important for all of our team, not only medical, surgical, radiation, but every one of us should take care of this point. That is why I wanted. Yes.
Regarding DEXA, I just wanted to add one point, because most of us often miss that DEXA required somebody uses PID doses, somebody uses PD doses, somebody tends to triple. But recent guidelines says that if DEXA daily dose is under 16 mg per day, so you can stop abruptly.
Under 16.
Under 16. 16 or 16 mg. You can stop. You don't need to go any tapering. So beta DEXA is a long acting. So routinely we used in chemotherapy. So DEXA is BD dose is adequate. Either you start with 4 mg or 8 mg when there's cord compressions or any high dose of radiotherapy is given. So 16 mg is the adequate dose. Because the randomized control trial has shown DEXA more than 16 mg. Somebody is striving 32 mg even per day. But DEXA more than 16 mg, it is
no tapering is
not going to give any issue and not going to give any benefit if it is increasing more than 16. So 16 is the standard dose. So particularly for breathlessness, particularly for other spinal cord compressions, when you need, so 8 mg ED is good enough. Start give for 5 days to 7 days, then taper it to 4 mg, stop it at such that this kind of hyperglycemic issue is can be easily taken care of if you give short doses up to 10 days or up to 12 days.
Again, concern from the medical oncology comes when the patient is on DEXA and planned for some immunotherapy. I'd like to take comments of Dr. Nagendra. What think we should keep in mind when DEXA or anything is required? So if it is absolutely required, most of the time we need to institute, but what things we should counsel the patient and our colleagues when the patient is on immunotherapy? For example, a patient is on maintenance avelumab, patient develops some neurological compromise, started on some treatment. Any concern or use of DEXA?
Right. So DEXA, we all know it's a steroid, and especially dexamethasone is a long-acting. Obviously, there are some side effects which we have to make sure that patient should cause gastritis, it can cause there are so much hyperglycemia, it can cause so many things are there which you have to make sure that they should be adequately treated by the patient is on therapy. Obviously, when the patient is on steroids, the immune response will be a little bit lesser. That also have to be communicated to the patient. And there are possible whenever we are stopping it, as I was mentioning, that we have to use it in a tapering dose of the stop. Except that it's points that are available in 16 milligram, you can stop it abruptly also if required.
So use the shortest schedule, which is required when the patient is on immunotherapy. That is also an important part, because there have been multiple trials which suggested the prednisolone 10 milligram equivalent is not a problem, but beyond that dose, it becomes a problem and it silences effect of immunotherapy. So it's another point which I wanted to bring in the multidisciplinary dissection like this, that when the patient is on immunotherapy or planned for starting immunotherapy, the doses of steroid should be as short as possible, and as has been discussed, keep it as lower as possible and as short as possible. So one last question from the core medical oncology. Dr. Anuj, I would request your comments. Yesterday, we had a very important debate, which is now there, that whether to institute nivolumab, the data of the checkpoint 901, which is there, that utilized Gemcis Nivo in the upfront setting versus Gemcis or Gem Carbo followed by avelumab maintenance. What is your take on that data? Because I know there is no clear head-to-head comparison, but it will be institutional and individual choice. But what's your choice?
So we have much mature data for Gemcis followed by avelumab, and we have already been practicing it from last a couple of years. So we know how the patient responds to that treatment, and the data also supports our practice. So that is the established practice, but with the upcoming data of nivolumab and with the results from the other low dose trial of nivolumab, when the patient is not affording for avelumab, then that can be a good option to incorporate low dose nivolumab to get a better result. So both options we should keep our minds open, also the patient, and both options can be.
Thank you. So I think we had very many discussions about Dr. Nagendra's talk covered a lot of aspects of the second line treatment, third line treatment. Kumar sir, I would like to get your comment on the second line treatment options. The patient has received Gem Carbo followed by avelumab maintenance. The patient has progressed in 4 months of avelumab maintenance. So now, what should we look at? The options available. So we have done NGS, don't have FGFR. Now, what are the options which we think will benefit the patients?
So one is the ideal one, and which there was a discussion in the very nice presentation by Dr. Nagendra, that you do have ADC, and if you can, that is a good option in that setting. If you have, if you don't, then you do have various of those chemotherapy, because one of the aspect of immunotherapy has been that it does something to the milieu, and somehow PFS and OS doesn't correlate, because, and this is true for almost any tumor. The PFS is pretty short, but then you see OS being good, because it looks like, and that concept is discussed in many tumors. And why I'm saying this, many that give treatment, that in the past when you've used those second, third line treatment, for chemotherapy, again, it becomes shorter. Remember, now this are a different group of patients, and the impact of this on OS could be different. So it is good to give it. We end up giving something, taxane is something which we fall back upon, many times, many situations where this was a drug for us to go to,
Yes.
and that what we do it at, this moment. And then you have the other drugs which has been used. Pemetrexed has been used. In our time, there was some data for Orlotti which we had used, which was not later substantiated. But remember that yes, the data is there, for that. So you have multiple drugs which has been used in this setting. Idea is that use it. One is the efficacy will be lesser, but remember these are after immunotherapy exposed patient, so the impact may be different.
Thank you. Thank you, sir, for this important comment. I think we could cover most of the gray areas in uro-oncology regarding the bladder cancer. Thank you, all the panelists. Thank you. Yes, sir. So in our practice, sir, we try to institute nab-paclitaxel in the routine practice, and because most of the time enfortumab vedotin is not available, sacituzumab is not available, not feasible. Another thing is that if the patient, we want to see the duration of last, for example, patient has received GemCis or Gem Carbo for 4 cycles or 6 cycles, then was put on available maintenance. If the duration of available maintenance has been more than 6 months, reinstitute Gem Carbo. That's the standard practice which we follow. Another point is, if on available maintenance we see the patient is progressing at a small new lesion has come up, try to ablate that lesion, institute nab-paclitaxel, continue avelumab. That is also an approach, because the disease has been controlled on avelumab for last 4 to 6 months, and only a small disease has come up now. It's likely that that particular area is resistance to immunotherapy. So take the biopsy, do the RFA if feasible, and continue avelumab, add nab-paclitaxel. That we have done even at Mumbai, sir, when I was under you, we had seen 1 or 2 cases like that and had reported this to you. And I think taxane plus immunotherapy always works in many cancers, not only urothelial. So that is also one of the approach. But these are all not supported by large trials, or unlikely there will be large trials on these gray areas. So that's the key. Think of all the available options which are available, especially in the gray areas. Yes. Thank you on the panelists. Thank you for the question.
As a pathologist, I would like to add 2 points. In case of bladder carcinoma, for a pathologist, 2 samples are very important. I will go back to Dr. Somnath's talk. Like he said that urine cytology. Urine cytology is a very important sample for us, because sometimes we find, as pathologists, we find difficulties in post chemotherapeutic urine samples. In normal urine samples, identifying the malignant cells is not a big job, but in patients undergoing chemotherapy, the urothelial cells show some form of atypia, that is chemotherapy-induced atypia. So at times it becomes challenging for us to distinguish between the malignant urothelial cells or these are the normal urothelial cells showing atypia. And second, for histology, like for a cystectomy specimen, it is one of the very tricky specimens for pathologists to cross, because we have to cover most of the areas. In many of the cases, what happens in post-chemotherapy cystectomy specimen, we don't see grossly visible tumor. So while grossing, it becomes very important to sample all the difficult looking areas, or different looking areas rather, I would say, from all the walls. So we prefer to take sections for every 0.5. Like, so we turn up giving 35 to 40 sections for bladder to completely rule out presence of any residual tumor, to call it a pathologic CR. So that 2 points I wanted to highlight to complete this whole discussion.
Thank you. Thank you. One additional point is that, sir, Kumar sir, we have started doing HER2 now in bladder cancer now. We have got around 8% positivity of HER2. So it's a very important point, because we know that HER2 positive anywhere in the body is going to have more aggressive. And these patients might be the patients who are not good responders to chemotherapy in the neoadjuvant setting. Hopefully, we'll be able to design a small trial, at least a phase 2 trial, where neoadjuvant trastuzumab addition might be beneficial rather than just gemcitabine alone. So and now phase 3 trial for tisotumab vedotin is also coming up. That will be also instituted in our center as a part of first line treatment option for patients who are HER2 positive at the baseline. So that trial will also come at Varanasi. So there's the additional points. Thank you. Thank you, everyone.
A heartfelt gratitude for an enlightening session, and it has added immense value to the conference. Now, moving on with the memento, I'd like to request our chairpersons to give the memento to our speakers and the panelists. So I'll request Dr. Vidhur sir to give the memento to Dr. Nagendra Sharma sir.